So this is just a single video I'm presenting with a lot of corneal opacity. I saw the patient on the slit lamp and I thought that it should be quite simple. And I told my DNB students as well. So but the situation is always different on the table. And when I was doing that, I could hardly have any view. This is under the retroillumination, thanks to the Lumera eye, that you can manage somehow. So I dyed the capsule, which again, you cannot see very comfortably. And I was just going ahead practically blindly with my Rexus, the capsulotomy needle. So once I did the Rexus, I was a little more confident because in these kind of cases where you don't really have a good view, you don't know what's going to happen. So I'd kept my extra capsular set ready. I'd kept my vitrectomy ready. I'd kept the anterior chamber lens ready. I normally don't do a direct chop. I normally I'm a still old traditional guy where I make a trench and then I tend to divide the nucleus. I could hardly have any views. I tried to partly divide it, and I took a couple of pieces, and then you can see my hand is shaking. The phaco probe is shaking because I was trembling because it was a private patient and you don't want to create any kind of complications. So once I got the hold of the nucleus, then it was a piece of cake for any one of our experienced surgeons. And I was able to remove the nucleus. But at all the time, my DNB student was assisting me. And I told them that you've got to be ready for any kind of uneventful complications on the table. Of course, once the cataract is removed, you can definitely have a very good flow under the retroillumination. And after that, of course, the lens was implanted simply. This is a slightly old video. So at that time, I didn't use the injector. And things went off nicely. But I just want to say that every day is not a Sunday. I mean to say I was lucky enough that I could get away, but I had to keep the things ready, mentally prepared. And also I had prepared the patient pre-operatively that I may or may not be able to the implant. And you may have some complication. I might have to put sutures or so. But by God's will, everything went off nicely. In one of the later conferences, I saw Dr. Noshe Shroff having a similar kind of a case with a lot of corneal opacity, and he used a chandelier light. And that's the time when it struck me that if you use a chandelier light, it works out very well. You have a good glow. And for my subsequent case, I did use chandelier light, and the things were much easier for me. So thank you for listening. And
Thank you, Dr. Sanjiv Mohan, for bringing out one more important thing. Is Dr. Praveen is there. Dr. Praveen, I wanted to ask this question with you. Now, Dr. Sanjiv Mohan has shown he has used Trifan Blue. He has not used endoilluminator in this case, but he has used it later. So that is also an understood fact. The other thing is, if in this particular case, would you think of doing a triple procedure, or would you think of doing a phaco only as was done by him?
Ma'am, I think I would see the status of the other eye.
Yeah.
First. I mean, what is the best corrected visual acuity? And there were multiple scars in the cornea. And if cataract was visually significant, I would rather first do cataract alone and then look for what is the outcome and then decide.
Yeah. And to all expert panel and Dr. Sanjiv Mohan too, if there was an inadvertent PCR has also occurred in this particular case, what would be your choice of IOL in this kind of an eye? Maybe more. There was some amount of clarity in the cornea in this particular case. Maybe it looked clearer after the cataract was removed. But what would be the secondary IOL you would plan to place if it's a PCR?
Well, if it's a PCR, at which stage it has happened, and if you can manage things, well, then obviously a glued IOL is the preferred IOL for my practice. As Dr. Sanjeev said, if the chandelier system would have helped, but had it been a mature cataract, then you would have used an endoilluminator for that matter. Retroillumination, he was using at times retroillumination, at times he was using the other illumination. And whenever he was using retroillumination, it was much better. Trypan blue staining is also a very important factor, which helps you see the capsule. So all said and done, coming back to the answer, a glued IOL for that matter, or it could have been implanted while doing the, if required, if you feel that corneal grafting would have been required, then it could have been done along with, or you could have done a glued IOL at this stage also.
Dr. Rajesh?
Sir, but why not multipiece IOL in the sulcus?
Yeah,
if there's a tear and if there's a nice
Agree.
rexis.
Yeah.
Yeah, if the rexis is intact, then it goes without saying. If the rexis is not intact, then obviously it goes, and you're not sure whether the IOL which you are trying to put would be stable. In those conditions, yes, a glued IOL. But if the rexis is intact, then it goes without saying that you can put a 3-piece IOL in the sulcus with the capturing of the optic.
And Rajesh,
No,
would you
sir,
think
but
of
in my, if I had a wrench and if the capsule was not intact with the way Dr. Rohitam Prakash is saying, I would have probably waited and visualized again the case and probably gone for a second stage of implant and probably reduce a less inflammation to the cornea, less damage to the cornea and to the endothelium. So that was my thought, what I had planned initially, which I told the patient as well.
Yeah. Rajesh?
Yeah.
What would you do?
In this condition?
If there's a PCR and you cannot place the lens in the sulcus.
See, if there's a rent and if there's a rent and I'm not sure about the anterior capsule as well, in such a case, I would leave the patient AFK and evaluate in the post-op period and then decide regarding putting the lens, whether in the sulcus or glued or whatever. If there is any doubt, I would, in such a case, I would, if I have some facility of, putting a chandelier illumination or putting an endo-illuminator, which I do in many occasions, then if I'm able to see that the anterior capsule is there probably, then I would put a multi-piece lens. If there's too much of haze and I'm not sure, I will leave the patient AFK and maybe evaluate at a further date and then decide about the type of lens that I have to put. And if it's too much of hazy, then maybe I have to think of some corneal procedure as well.
Yes, thank you very much. Thanks a lot, Dr. Sanjiv. That was one more interesting situation you posed for more discussion and more learning for